Everybody, thank you very much, Lawrence. It's a great pleasure and a great honor to be here with you. And I know you don't like very much to be thanked, but I would like to thank you again very much for your kindness and for your invitation. The work I'm going to present to you is about ultrasound and MRI in prenatal diagnosis and how these two modalities can complement each other. You probably know that both ultrasound and MRI can provide with very different signs and ways to image the fetus in the uterus, and these two modalities complement quite well together. And this is basically the plan of my brief overview for today. So, as an introduction, I would like to remind you that the main modality to image the fetus is ultrasound, and there are all over the world many guidelines stating how you should image the fetus and what kind of image you should do, whatever the trimester you are scanning. But although ultrasound has many advantages, it also has some limitations, and there are growing demands for alternatives to ultrasound. What can be these limitations? The limitations can be related to beam attenuation or obesity, to the increased incidence of multiple pregnancy, to the increased incidence of obesity, to poor fetal position, to poor tissue contrast, or to the limited field of view that you can have with ultrasound. And on the opposite, there is an increasing demand to recognize prenatally congenital anomalies that can lead to a severe handicap and morbidity at long term. And there are increasing medical legal issues in obstetrics and in prenatal diagnosis. This guy can be seen as a visionary doctor. This guy is Professor Francis Smith, and he first published in 1983 in the Lancet journal about the use of MRI in pregnancy, and he concluded in this article that nevertheless we believe that it will prove to be safe, and that the absence of ionizing radiation, the superior tissue definition compared with ultrasound, and the ability to study tissue water will give it wide application in obstetric practice. And you can see that he was quite right, because now if you just type fetal MRI on PubMed, you'll get more than 4,000 hits. Actually, fetal MRI can be seen as a kind of problem-solving tool whenever you've got ultrasound insufficiencies or limitations. And you probably know that apart from quite funny incidents, MRI is safe during pregnancy, and you can now use it with no problem. There is a lot of literature showing that you can use MRI during pregnancy. So ultrasound and MRI could be a happy marriage, because ultrasound is widely available, it's easy and simple to perform, it's safe, it allows real-time imaging, and has a high spatial resolution. Whereas on the opposite, MRI has a lower availability but a high contrast resolution. One of the good points with MRI is that you almost have no limited field of view, and it allows you to image the entire fetus in one sequence. And this can be quite interesting, especially when you are in the setting of maternal obesity. And you can see that this is a big and ever-growing issue. And you can see that even with MRI, you can image an obese pregnant woman. And here on that slide, you can see the incidence of a high body mass index in various countries over the world. I cannot find Israel, but I think you are all very fit in Israel. And you probably know that the higher the BMI, the lower the recognition of congenital anomalies, so this is really a big issue. So for the introduction, you must remember that MRI will complement ultrasound in case of ultrasound limitations, or in case of fetal anomaly or high risk of anomaly. So now we are going to see what kind of additional information you can obtain with an MRI as compared to ultrasound, which is the main modality for imaging during pregnancy. For the central nervous system, there are some guidelines stating what you should see in the fetal brain and in the central nervous system of a fetus. But MRI can be very interesting and should be prescribed whenever it is possible in case of ventriculomegaly, midline or corpus callosum abnormalities, posterior fossa abnormalities, suspicion of parenchymal lesions, or in case of high risk of anomalies such as twin-to-twin transfusion syndrome, infection, etc. The optimal gestational age at which you should perform the MRI is quite controversial. It depends on the availability of MRI. It depends on your legal regulations about termination of pregnancy. In France, we used to perform the MRI late in the second trimester or early in the third trimester because it's a good compromise between sulcation development and parenchymal maturation. With MRI, you'll be able to obtain brain biometry, which is quite different from the skull biometry that you obtain with ultrasound. And you can see how well the brain is developing. And now you have reference ranges to see if these biometry are normal or not. More interesting, you can very easily see the normal sulcation of the brain all across gestation, which is quite difficult to observe in ultrasound, and you can see that it's quite straightforward as long as you know the anatomy of the normal fetal brain with MRI, and you can use the three different planes of space, either axial, sagittal, or coronal, to look for the normal development of the brain sulcation. Of course, you have to know that these aspects change all along gestation as the brain is getting older and older. So with MRI, you'll be able to pick up quite easily some sulcation anomaly, as that one which is secondary to ischemic damage. And you can see that it can be more challenging in ultrasound, mainly because of the beam attenuation due to the shadowing of the fetal skull. This is another example of how MRI can help to diagnose brain anomaly. This is a case of lissencephaly. Of course, this should be seen on ultrasound, but you can see that it's very easy to see those lesions at MRI. The normal development of the parenchyma can also be seen on MRI. You can see the different layer patterns, and you can see if it's developing well or not. Myelination process can also be seen on MRI, and you can see as well the normal development of the myelination process, and you can look for the normal parenchymal development. This is a case of CMV infection, and you can see that you've got some hypersignal of the white matter, and MRI will allow you to describe very well this MRI hypersignal, and we've developed a quantitative way to assess those hypersignal in order to make this appreciation and this categorization more reproducible. And this is a work from Benjamin Deloison, Anne Demicher, and Pascal Soligo, which is now under publication. Midline anomalies can also be seen both on ultrasound and MRI, and you can see that with MRI you have a very good visualization of the corpus callosum and of the midline. And MRI is especially indicated to look for associated anomalies. This should not be used to diagnose corpus callosum anomaly. That is quite obvious on ultrasound, but this should be used to look for additional anomaly. This is an example of corpus callosum agenesis on MRI. Last, for the brain, posterior fossa anomaly is a good indication for fetal MRI, especially in the third trimester, because we believe that in the second trimester, ultrasound performs better than MRI to look for posterior fossa anomalies. An interesting field is the development of new methods to image the fetal brain, and these methods are related to functional imaging of the brain. The team from Daniela Pryor is quite prolific on that subject. They are developing new ways to image the fetal brain, either at rest or either functioning, and these are some very interesting images. This one comes from the team of Marseille, from Nadine Gérard, and this one again are images from the team of Daniela Pryor and Gregor Castrian, and you can see that they perform tractography in the fetus, and these are quite nice images. So for the brain, you must remember that MRI will allow you to look for normal cerebral biometry, normal sulcation, normal parenchyma, myelination, posterior fossa, and there is a developing field in the imaging of the brain function. thorax now, we can see quite a lot of lung anomalies in the fetus, and one of the main anomalies we have to deal with is congenital diaphragmatic hernia. This is related to a defect in the diaphragm, and then the organs that are normally in the abdomen will go up to the thorax and hamper the normal development of the lung. You can see that with MRI, you can very well look for the normal development of the diaphragm, either on static images or on dynamic images, where you can see again the normal diaphragm. And one of the most important prognostic factors for congenital diaphragmatic hernia is the normal development of the fetal lungs. And one way to look for the normal development of the fetal lung is to look for the lung-to-head ratio at ultrasound. The lung-to-head ratio is the ratio between the surface of the contralateral lung, contralateral to the hernia, and the head circumference. And this is quite predictive of the overall survival. There have been now many works about that, and we know that lung-to-head ratio is directly related to postnatal survival. And another way to look for the normal development of the fetal lung, these are two cases of congenital diaphragmatic hernia seen on MRI, is to assess the fetal lung volume using MRI. You can use axial views of the fetal lung and then use these axial views to calculate the lung volume. And this lung volume, as the lung-to-head ratio, is directly related to the overall survival. MRI could also be useful for congenital diaphragmatic hernia to differentiate between hernia and sac. And these two pathologies have different prognosis. For the lung again, MRI can help you in the management of cysts of the lung or masses of the lung.